Hello, colleagues, ladies and gentlemen. Great pleasure to welcome you to Revolution Heart Failure Seminar number 1. This is a very important initiative that's done a needs assessment for education for physicians and allied health workers, but also incorporating patient views across heart failure across the world. And we've been running for some time now, but this is the first of the external webinars. It's been an initiative that's involved about 500 healthcare professionals, as well as expert patients inputting onto what they feel is needed. So it's a very important insight. So this first thing, we'll be looking at real-world practice of heart failure care. We have an excellent faculty. We have about 20 faculty to choose from, and we have about half a dozen here today. My co-chair is Eva Jankowska from Wrocław in Poland, but we also have representatives from the whole faculty that straddle, the North, Central, South America, Europe, and also Asia. So we have a global perspective. Today, I've got great pleasure in also introducing Shelley Zeroth from Canada, Lars Lund from Sweden, Michel Comajda from France, along with Yuhui Zhang from China, Peter Liu from Canada, and Martin Cowie from the UK. I'd like to get on now, and I'll introduce Eva, who can perhaps introduce the first of our two speeches, two talks, and then we'll have time for discussion, 10-minute discussion at the end of each one. Eva.
Andrew, thank you very much. I think it's really great pleasure to be here with all of you and running this very important educational initiative. Without further ado, I would like to introduce the first part, during which we all discuss the evidence regarding epidemiology, geographical, national differences, and also gaps in heart failure implementation, together with the global consensus on classification of heart failure. So I would like to invite the professors Shelley Zeroth, Lars Lund, and Michel Comajda to present the lectures.
Welcome to Real World Heart Failure Management, a global overview. I'm Shelley Zeroth from Winnipeg, Canada, and I'm going to speak to you about the new universal definition and classification of heart failure. These are my disclosures. Well, the universal definition and classification of heart failure was a joint endeavor by the Heart Failure Society of America, the ESC Heart Failure Association, and the Japanese Heart Failure Society. I'm proud to say that the Canadian Heart Failure Society also endorsed this. And this was an important consensus document to provide a simple, clinically relevant, and conceptual comprehensive definition of heart failure. And it was chaired by the masterful Professor Beacom Boskert, along with Andrew Coates and Professor Tsusui. This is the universal definition and classification of heart failure. It requires symptoms and or signs of heart failure caused by structural and or functional cardiac abnormalities, including valvular heart disease and LVH, for example. And it must be corroborated by at least one of the following, including elevated natriuretic peptide levels or objective evidence of cardiogenic, pulmonary, or systemic congestion. And you can see them defined on the left-hand side of this panel as well. These are the new heart failure stages, including stage A, those individuals at risk for heart failure. And this would include people with hypertension, diabetes, obesity, cardiovascular disease, exposure to cardiotoxins, and a family history of heart failure as well. Then we progress to stage B, those individuals without symptoms, but evidence of structural heart disease. Stage C, we see in many of our heart failure clinics, those individuals with symptomatic heart failure. And then finally, stage D, those individuals with the most severe refractory symptoms related to heart failure. And I think this is an important element of the new universal definition, the classification by left ventricular ejection fraction. We're all very familiar with HFrEF being defined as an ejection fraction less than or equal to 40%. Mildly reduced ejection fraction is getting a lot of attention these days and is defined as those individuals with an ejection fraction between 41 and 49%, HFpEF with an ejection fraction of greater than or equal to 50%, and then heart failure with improved ejection fraction, something that we strive for in all of our HFrEF patients, is defined as those individuals with an ejection fraction at baseline of less than 40%, who then have a sustained 10-point increase from baseline in their ejection fraction on a second measurement. And with that, I'm going to turn it over to Professor Lund, who will be speaking to you about global epidemiology and the burden of heart failure.